Good evening, everybody. So we're just going to do some nephrology questions. So if anybody's got doubts, you can ask me there and then. I think people send some messages, but some reason when I'm doing the presentation, it's Zoom doesn't show me the messages. I don't know whether it is something to do with the setup I have or not. So you can stop me and ask me question there and then. I don't mind. After each question, once we discuss the answers, you can ask me there and then. It's a lot more easier for me to go through them as well. We can go back to the question, you can look at the answers and give me your thoughts and so on. Okay. If you have any other doubts, you can send me a message, give me a message at the end. But during the the class, when I'm doing the questions, it's difficult to go through your messages. It actually doesn't, for some reason, I think Zoom doesn't show that to me very well. Okay. So good evening. We'll start.
Good evening.
So if you're not able to see or anything is not clear, please ask me again. It's a 65-year-old man who presents to the GP, just 1 second, with a 3-month history of progressive breathlessness, weight loss, and the productive cough. He's got history of bone pain. He's got hypertension, usually well controlled. And on examination, with the one significant abnormality that you identify is that he's got a left-sided varicocele. His observations are as follows. His blood pressure is high. He's a little bit hypoxic, and his respiratory rate is about 23 beats per minute. And these are the investigations. He's got anemia with a hemoglobin 9.2. He's got leukocytosis. White count is a bit high. Platelets are normal. He's got a high serum calcium, and serum creatinine is also significantly elevated. And the urine analysis shows a protein and the blood. So to summarize, so he's a gentleman who's got a history of weight loss, breathlessness, bone pain. He's got a varicocele. He's hypertensive, and he's got a renal impairment with hypercalcemia and blood and protein in the urine. Okay. So what sort of things will go through your mind?
Renal cell carcinoma with metastasis.
Renal cell carcinoma. Yeah, RCC.
Can you guys hear me? I'm not able to hear any of you. Just 1 second. Is it not muted? What sort of things go through your mind? I've not received any response.
It looks like a carcinoma which could have metastasized.
Okay. Yeah, go
and
on.
Because there is bone pains which the patient is having, there is anemia which the patient is having. Also, the presence of left varicocele makes it possible of being a renal cell carcinoma.
Okay. Very good. Okay. So I'm hearing some other audio in the background. I'm not sure. Okay, fine. That's very good. Okay. So what is odd about it? If we suspect renal cell carcinoma, what is odd? What is the odd thing here? Anyone?
What's the sir? Please.
What is the odd thing? That is something which is out of the normal presentation that you would expect in a setting of renal cell carcinoma. What is different? What else is something odd here, or something which is different than what you could have expected?
There is polycythemia, sir.
Exactly. Very good. Okay, because these one of the classical triad of exactly, that's right. Because these carcinomas also produced erythropoietin. So generally these patients are polycythemic, but a significant proportion will also have anemia. So that is one of the reasons for putting up this question. So though classical presentation will be with polycythemia, here, given the history, varicocele, etc., which makes it more likely that this renal carcinoma, and with pressing on the left renal vein and the vein going down to the testis as well. That is why he's got varicocele. Very good. Okay. So these are the options. I mean, anyway, we've gone through it already. So the other thing you need to bear in mind is small cell lung cancer, which does cause a lot of paraneoplastic syndromes. However, it does not explain the varicocele unless you think it's due to some sort of a secondaries in the abdomen or something like that. And also, it doesn't typically cause hypercalcemia, which you see that with. What sort of lung cancer would we see hypercalcemia with?
Squamous cell.
Exactly, that's right. Squamous cell carcinoma. Very good. Okay. And the prostate cancer may explain some of the symptoms, but doesn't explain all the symptoms the patient has, particularly the respiratory symptoms, etc. So based on the information we have, as I said, it's most likely that he's got a renal cell carcinoma. Very good. Okay, right. Let's move to the next one. Right. So this is, you are seeing a 38-year-old man with an autosomal dominant polycystic kidney disease in the renal clinic. Which of the following medicines would be useful to slow the progression of his disease? So you got some guy with polycystic kidney disease, as most of you know, it's going to be a slowly progressive kidney disease, and with substantial proportion ending up needing renal replacement therapy. So the question is there any drug or any medicine which we can use to slow the progression of his kidney disease?
Valsartan.
Okay, I've given you the options. Please wait. Yeah. So eplerenone, which is a mineralocorticoid receptor antagonist, triamcinolone, it's a potassium sparing diuretic, and we have tolvaptan, it's a V2 receptor antagonist, indapamide is a thiazide diuretic, and demeclocycline. So which of these drugs will help to slow down the progression of polycystic kidney disease?
So tolvaptan.
Okay. Any other options, anyone?
Demeclocycline.
No, it doesn't really have any role on that. No, tolvaptan is the right answer. See, tolvaptan, what does it do? What sort of drug is it?
It is a vasopressin antagonist.
That's right. It's a V2 receptor antagonist. And actually, you use it for, when else we use tolvaptan?
Hyponatremia also.
That's right. So particularly in SADH or hyponatremia with volume overload like heart failure, chronic liver disease, kidney disease, etc. Though it is classically used for SADH, it's also can be used to slow down the progression of kidney disease. By what it does is it reduces the cyst growth over time. Basically, what happens in polycystic kidney disease? No, the cysts gradually increase in size over time. So they tend to get bigger and bigger kidneys over time, which leads to all sorts of problems like pain, infections, bleeding, and even last week I had a patient with a very nasty sepsis from a bleeding into the cyst, polycystic kidney disease, and eventually end-stage kidney disease. So there is plenty of evidence that tolvaptan is useful in reducing the cyst growth and reduces or delays the progression of kidney disease. One second. See, when you come to, as I always say, when you come to one condition, it's not just about focusing on the answer. There are a couple of other things with regards to, so what sort of things we need to bear in mind when we're giving somebody tolvaptan? Because these are all different questions you may come in this sort of topic area. Anyone does know what monitoring we need to do when we give tolvaptan? Anyone? Okay.
Sir, can you repeat the question?
No. Is there anything we need to monitor biochemically or otherwise when we treat somebody with tolvaptan, whether it is for polycystic kidney disease or SADH, the same rule applies.
Creatine.
Sorry?
Sodium.
It doesn't, see, we are not, obviously if we're giving it for hyponatremia, you need to monitor the sodium.
Hypertension, sir?
No, it doesn't cause hypertension. No, it does not. It doesn't cause hypertension. It's a diuretic. How can we expect it to cause hypertension? Imagine.
LFT.
Exactly. No, LFT, that's right. Correct. Yeah. There is a small but significant risk of liver injury with this tolvaptan. So if you initiate somebody on tolvaptan, particularly in the setting of polycystic kidney disease, you need to monitor the liver function periodically. Actually, that is what delayed the license of tolvaptan for a long time in the use of polycystic kidney disease. So if you're giving tolvaptan, actually, I do the same thing in clinical practice. Even if you give it for SADH, you should at least have an LFT at the baseline. And if you go the course beyond 2-3 weeks, it's always check the LFT periodically. The risk is only about 1%, but there have been reports of fatal liver injury with tolvaptan. So you need to be aware of that. And certainly something we should do if we are giving tolvaptan for the purpose of polycystic kidney disease. Yeah? Okay? Right. The other thing, what else is important in polycystic kidney disease? I have not put slides, but I just thought it's important to discuss it.
Aneurysms, very aneurysms.
That's right. Yeah, exactly. So sometimes what happens is there may be a question about a scenario where you have a patient with polycystic kidney disease, okay, who's got a relative who's got a history of subarachnoid hemorrhage. Okay, so important to connect those two. So people with first-degree relative who have had subarachnoid hemorrhage are at a higher risk of subarachnoid hemorrhage. So that is what the risk you will check. So you got a scenario where they're asking, this patient has got a family history or whatever of subarachnoid hemorrhage. But in the first-degree relative, these patients also have a higher risk of subarachnoid hemorrhage, particularly young women, etc., have a higher risk of. So that's also something to bear in mind with regards to polycystic kidney disease. The other option, I think somebody mentioned that already, In case if tolvaptan is not given, but they give, let's say, ACE inhibitors or ARB, they are also equally important in the setting of hypertension in APKD. So if somebody's got hypertension, the drug of choice would be ACE or an ARB. Both have got evidence to slow the progression of polycystic kidney disease. But beyond that, we have tolvaptan. In terms of reducing the cyst size, reducing the complications with polycystic kidney disease, tolvaptan is the drug of choice. Okay. There are some criteria and all you need to follow, probably not relevant in the setting of MRCP level, but there's sort of, you look at the cyst growth over time, the total kidney volume, etc. Just something to bear in mind. Okay. The other question which frequently comes up in polycystic kidney disease is what is the next one we need to worry about? It's a congenital disorder. So let's say what sort of things you will be asked or you need to be aware of. Is the
other cyst
prolapse.
Yeah. So in the exam setup, what you need to know is about the cyst in the other organ areas that may give you a hint, like cyst in the liver, cyst in the pancreas, etc. That may give, like say, they may give a scenario, but somebody got cyst in the kidney, cyst there, and then that will be strongly suggestive of polycystic kidney disease. And these patients have a high risk of hypertension, high risk of atherosclerotic cardiovascular disease, etc. The other thing which you need to bear in mind would be the diagnostic criteria, because let's say sometimes what they will do is they will say this patient has come. They got a young son, 16 or 20, whatever. They want to know whether the child has got, or the child or the son, daughter, whatever, has got any evidence of polycystic kidney disease. So what would you do? What would you advise or recommend?
Genetic analysis?
You can do that, but unfortunately, it can be not necessarily very much diagnostic. The more useful thing will be ultrasound. Right? But no point in doing it before the age of 25. It's not going to give you the correct answer, because a lot of the time you may be falsely reassured that there are no cysts in the kidney, because these cysts don't generally appear, or they are maybe too small to be picked up on the ultrasound till about 20-25. So generally we won't advise it. So then the next question will be about on the basis of number of cysts in each kidney depending on age, because a lot of people have acquired cystic kidney disease. That is, they will develop some cyst in the kidney, which, like, let's say I'm scanning a 50-year-old guy for hypertension, renal impairment. I find one cyst in each kidney. It's probably not polycystic kidney disease. So there are some criteria you also need to be aware of. I'm just going to go through that in a minute. I'll check with you guys. So as you know, it's the autosomal dominant polycystic kidney disease. It's the most common inherited form. The other one is the recessive one, which happens in the childhood. Yeah. Okay, those people will develop renal failure at very, very young age, in the first year of birth or something like that. And unfortunately, they do not survive for very long. So we have a PKD 1 and 2 for polycystin 1 and 2. Predominantly, it's a type 1 in 85%, and they generally present renal failure a lot more earlier, and it's in chromosome 16. And type 2 is the remaining 15% or so. That is in chromosome 4. That is PKD2. So just something to be aware of. So if we want to check whether somebody's got a suspected polycystic kidney disease, particularly if they got families, that's very important. You don't screen everybody and say this could be polycystic kidney disease. So either if they are less than 30, they need to have 2 cysts, either unilateral or bilateral. And if they're between 30 and 59, 2 cysts in both kidneys, and beyond the age of 60, it's 4 cysts in both the kidneys. So this diagnostic criteria you need to be aware of, because sometimes they will ask questions about that, about what is the diagnostic criteria for polycystic kidney disease. So these are the main things which will come up in the topic of polycystic kidney disease. Yeah. And this is how tolvaptan works. Just picture, not really, mainly basically it acts on the V2 receptor, and eventually it leads to increased excretion of water, so decreases the cyst growth and also reduces total kidney volume. That is what's called TKV. I mentioned that briefly, but you don't need to know too much about it. But what is that? Basically, the bottom line is that it works on the V2 receptor, and over time it reduces the cyst growth over time. And because the problem in polycystic kidney disease is the increased expression of aquaporin. So that is via the V2 receptor, you can downregulate that. Okay. So actually, one of the other treatment that we commonly recommend to polycystic kidney patients is to drink a lot of water. That also downregulates the system. So that is also a simple solution for patients with polycystic kidney disease. You ask them to make sure they drink a lot of water. So this is about the side effects of tolvaptan. I said it is not a polyuria, thirst and all, increased urination, etc. That and all, usually we can manage that. It's not a big problem. But liver toxicity, I said, is very rare. I mean, it's less than only 0.5%, but there's been reports of fatal liver injury. That's why it's important to monitor the liver function test when you are treating patients with tolvaptan, particularly for polycystic kidney disease, because you're going to treat them for a longer period of time. Okay, any questions on that?
Can
Before
this
I move
be
to the next.
used? Can this be used in polycystic kidney disease with normal sodium levels, sir? Or
Yeah, definitely. Yeah, it's got nothing to do in this setup. We are not giving it for sodium at all.
Okay.
You are giving it to, as I mentioned, you are giving it to reduce the cyst growth or slow down the cyst growth. That is
Okay.
what the purpose is. It's got nothing to do with the sodium in this setup.
Okay.
It is all because it's an aquaretic. So basically, aqua means water. It makes you get rid of water. Because in most patients with hyponatremia, particularly SADH, what do you have? I have not got any question on that. Maybe next time I'll put a question. So it may be covered in endocrine, but it's also partly renal. So basically, what you have is your total body sodium content is the normal, but you have more retention of water, isn't it? That is what happens in syndrome of inappropriate ADH. So
Yes, sir.
you have a hyponatremia. So giving tolvaptan, that will get rid of, it doesn't have any effect on the sodium. It makes you get rid of more the water that you accumulated. Yeah.
Okay, sir.
So that what happens is, but tolvaptan does not cause hypernatremia in normal individuals. I mean, in patients who have a normal sodium levels. Yeah, it does not do that.
Thank you, sir. Thank you.
Okay, not a problem. So it doesn't have much effect on the blood pressure. It doesn't have much effect on anything else. It doesn't generally come. I use it frequently in the setting of hyponatremia and also in APKD, etc. It's not a drug which causes hypotension, but the nuisance is the polyuria is the problem, because people frequently complain of polyuria. So you need to tell them these patients need to drink a lot of water. Okay, so it's unfortunately it's a little bit of an expensive drug in the long run, particularly if you're in a country like ours. So that's something to bear in mind. But generally, it's usually well tolerated, etc. Yeah. 1 second. Sir, just give me 30 seconds. I'll just get some water. I left it. Just 1 second. Well, just to 10 seconds. Sorry, I'm back. Just 1 second. My slide. 1 second. 1 second. Oh, this room is such a user-friendly one. Okay. Yeah. Okay. So, any questions till that in that area, subject area, whatever? Because polycystic kidney disease is one of the common genetic disorders that you will face in MRCP exams, and also, obviously, it's the commonest genetic disorder in renal medicine, nephrology. So, you all need to know, the most bits about polycystic kidney disease. So, if no questions, I'll move to the next one. Yeah.
Sir,
yeah.
Sir, if AC inhibitors were told in that question, is AC inhibitors more preferable over tolvaptan?
No, you see, it's very unlikely they will confuse you with that. You need to read the wordings of that. If they say, if there's somebody's hypertension or something like that, then perhaps you can choose AS or ARB. But if there's a question is about what drug will help to reduce the progression of polycystic kidney disease or reduce the cyst growth, etc., you have to choose tolvaptan. You can never be absolutely certain, but it's very unlikely somebody will put a question there with confusing you to choose between the two, because in practice, if somebody's not hypertensive, you're not going to use AS or ARB. Yeah.
Okay, sir.
Yeah.
Sure.
So that will be, yeah. Any other questions? Otherwise, I'll move to the next one. Yeah. Okay. Fine. We did some of these nephrotic syndrome questions before, but still, it's certain areas may not have been covered. Okay. I tried to make sure that they don't get repeated, the same questions as before. A 60-year-old man presents with history of leg swelling and weight loss. On examination, you notice that he's got pitting edema up to the groin. A serum creatinine is normal. A serum albumin is low. 24 urine protein excretion is 5.6 grams. So obviously, that is what we call as a nephrotic range proteinuria. I mean, different books and everything will say different numbers. It's generally more than 3.5 or 4 grams is what we classify as nephrotic range proteinuria. So he's got edema, he's got hypolipinemia, he's got nephrotic range proteinuria. So he's got nephrotic syndrome, no doubt about that. His chest X-ray shows a mass in the left apex. Okay. But these are the options. But anyway, I thought I'd go without discussing it. But anyway, never mind. Okay. So he's got a nephrotic syndrome. There is a suspicion of a mass in the lungs. And so the question is, what is the most likely diagnosis? So you got a focal segmental glomerular sclerosis, IgA nephropathy, amyloidosis, minimal change disease, membranous glomerulonephritis. All of them are causes of nephrotic syndrome in adults. Yeah. Yes, correct.
Membranous glomerulonephritis.
Why do you say that?
Because this nephrotic
Nephrotic range proteinuria is seen common in
Why can't it
membranous
be minimal?
glomerulonephritis.
That is not the reason. That is the answer. Why can't it be minimal change disease?
Lung cancer is associated with
Exactly. That is the
Lung
point.
malignancy.
That is the point. Yeah. Membranous nephropathy is the most common most common cause of nephrotic syndrome in the setting of malignancy. That is why it's membranous nephropathy. It's not because of nephrotic syndrome, because minimal change also can give you nephrotic syndrome. Typically, it happens in children and young adults. But I have seen even 80-year-olds with minimal change disease. It does happen. Amyloid, there is no suggestion of something else like long-standing chronic disorder or etc. IgA nephropathy can give you nephrotic syndrome, so typically it doesn't. And the FSGS also gives a nephrotic syndrome. So, but because of the presence of malignancy only, we're choosing membranous nephropathy as the likely diagnosis. Okay, right. Oh, one additional thing I forgot, and it's there actually. I mean, I should have asked the question. Never mind. So the other thing to bear in mind is when somebody is nephrotic with low albumin, they have increased risk of thrombosis. Yeah, you guys are familiar with that? We frequently anticoagulate. But does anybody know which of these nephrotic syndromes? Yeah, there's something I want to discuss. That's why I put the note there. Is because it's really impossible to cover every question. No, that's why I put these things there, so that I don't forget to discuss these things. The thing to remember is that there is a increased risk of thrombosis with nephrotic syndromes, particularly when they have a low albumin, the risk is high. So generally, people with albumin level of less than 2, we would consider anticoagulation for them till the nephrotic syndrome is resolved, because these people can develop all sorts of thrombosis. You see people in clinical practice with pulmonary embolism, DVT, even bowel infarction secondary to thrombosis in the setting of nephrotic syndrome. So does anybody know about any connection between risk of thrombosis and the type of nephrotic syndrome? Anyone?
Because
more common with the minimal change, sir.
no, because of secretion.
No. I was not asking about the cause. I was asking with regards to different etiologies of different nephrotic syndrome like membranous, minimal change, FSCS, etc. Which of the following has got the highest risk of thrombosis? Anyone know? Anyone else?
Minimal change.
Because loss of antithrombin 3.
No, I heard the minimal change. Yeah, sorry. I heard that. Anyone else? I said any other. No, I was not asking why it happens. My point was which of these things is more likely to be linked with increased risk of thrombosis. Out of all these 5 options, let's say the same options, which of this the one is the most likely linked to be malignancy? Sorry, thrombosis.
FSGS. Again, we have to go for membranous, sir.
Exactly, correct. That's right. Membranous is the one with the highest risk of thrombosis among all nephrotic syndrome. The risk of thrombosis membranous is many-fold higher compared to all other causes of nephrotic syndrome. Okay, so just again, sometimes question may be asked on that. That's why I wanted to be reminded to be put on put a note here that discuss about the increased risk of thrombosis. So malignancy, membranous nephropathy, increased risk of thrombosis. And then other thing, membranous nephropathy, we discussed it last week, is a connection with SLE. You remember that? Not last week, 2 weeks before I discussed it. You remember? Yes, SLE will cause class 5 class 5 lupus nephritis is membranous nephropathy.
Membranous.
So these are the things you need to remember. And the other thing which we frequently come across is I'm going to question we may get asked is I'm going to the next question. Okay. So let's assume it's the same patient or a different patient who's got 1 month history of leg swelling. You examined, she's got leg edema. Your creatinine is normal. Again, she's got nephrotic range proteinuria. serum albumin level is low. Okay, the patient undergoes renal biopsy. So this is, if you people doing part 1, it may be a tougher one. Part 2, this just so you see all this thickening of this glomerular membranes in the capillary loops. This is typically what you will get in
Focal segmental cells.
No. See, why is it called focal and segmental?
Because
Membranous nephropathy.
This is membranous nephropathy. No, the reason you should remember why is it called
focal
focal
and
and
segmental, sir, not diffuse.
Yeah,
Hello?
exactly. The whole glomeruli won't be affected. Exactly. The answer is there itself. Why is it called focal? Because only some of the glomeruli will be affected. Okay. So that is, you can't interpret from that because you got only one glomerulus here. The segmental means within each glomerulus, only part of the glomerulus will be affected. Here, you can see that the whole of glomerulus looks very similar. Yeah. And all these thick pink stuff are capillary loops. They're all very, very thick. This is classically what you will see with membranous nephropathies.
Okay.
Yeah, okay. Now,
Yes,
that
sir.
is not the question, but I just put a slide so that you know about these things. Particularly for people doing part 2, sometimes they'll put a picture of a membranous nephropathy picture.
Correct.
Right. This is the question actually in this one. So which of these antibodies associated with this biopsy diagnosis? So she got a membranous nephropathy, and these are the different types of antibodies you will have: antiphospholipase A2, anti-SCCP, anti-SCL70, anti-centromere, and anti-double-stranded DNA.
Antiphospholipase A2.
Very good. No, it's actually, sorry, I already answered that because the correct answer, I didn't ask anybody else. Very good. It is antiphospholipase A2. That is one of the major causes of primary membranous nephropathy nowadays. In the olden days, what we used to call as idiopathic is actually linked all to antiphospholipase A2 receptor antibody. All the other things are nothing to, you can't think if it's given a setup of SLE and all, then you may think about double-stranded DNA antibodies. But typically in membranous, particularly in the primary membranous, the most common antibody that you will see is antiphospholipase A2 receptor. That is also called as PLA2 receptor antibody. Yeah, it's called a PLA2R antibody. And there is, just in case if you remember, hopefully they won't ask, there is also another antibody recently been identified called NEL, NELL. But hopefully it's more of a nephrology specific topic rather than this one. And which we also screen nowadays for in the setting of membranous nephropathy. But PLA2R is typically present in the primary membranous nephropathy. As I said, you have this primary idiopathic membranous nephrosis typically related to these PLA2R antibodies. So there are various causes of membranous nephropathy, and as idiopathic, which is related to PLA2R, you can have it with infections, hepatitis B, malaria, syphilis. We don't use these drugs anymore, gold, penicillin. NSAIDs, more of theoretical relief. NSAIDs typically cause, what sort of nephrotic syndromes NSAIDs cause? Anyone?
Interstitial.
No, that is not nephrotic syndrome. Good, that is a point. Actually, NSAIDs, I always tell people, it causes all sorts of renal pathologies you can imagine. Huh?
Can it cause
Please
minimal change nephropathy?
That's right. Yeah, NSAIDs can lead to minimal change disease. That's right. Yeah. See, NSAIDs are one class of drugs which cause all sort of pathology in the setting of kidney. It can cause a pre-renal renal disease. Remember, we discussed a hypolemia patient last time. Basically, somebody who's coming hypolemia, they'll be taking NSAIDs. So what will NSAIDs do? They will inhibit. What is it called? Exactly, that's right. Yeah, prostaglandin. Because normally, if you get a hypolemia, you'll open up afferent, which is mediated by prostaglandin. So if you take NSAIDs, you cannot do that. That is the reason why there are pre-renal renal failure in the setting of NSAID. It was a minimal change disease, as somebody already mentioned. It can also cause an interstitial nephritis. So it causes pre-renal, renal, and also causes post-renal. What post-renal thing NSAIDs will cause? It's a bit of a tough question, but it's not really that. It's correlatively, it's important. You should know it causes papillary necrosis. You familiar with that?
Yes, sir. Yes, sir.
Yeah.
Papillary.
So it can cause papillary necrosis. You typically, MRCP exam stuff wise, you typically see it in the setting of sickle cell trait. But NSAID is also common cause. Having said that, in India, we frequently see it in people with very, very, very poorly controlled diabetes, developing nasty pyelonephritis, causing papillary necrosis. But gold and penicillin, we no longer use them much, but in the exam setup, you need to know And the SLE, rheumatoid, thyroid, all of this we've already mentioned. So 2 to 3 things with membranous nephropathy you need to know. One, which is the antibody, the PLA2 or antibody you should know. Second is the association with malignancy. Third is the increased risk of thrombosis. And fourth is a connection with the SLE when you have class 5. These are the important points when you have membranous in the setting of MRCP exam. Okay. Sorry, any questions on that before I move on?
No, sir.
Okay, so it's all clear. So I said that's fine. Good, very good. 1 second. So if you have any question, as I said, please ask me there and then best guess. Some reason I'm not able to access the chats when I'm doing it because it doesn't show up that one. I don't know. I have to go to multiple screens. Right. Okay. A 52-year-old man. He's got end-stage renal disease, secondary to diabetes, undergoes a kidney transplantation. And with no immediate complications, 2 months later, he attends the emergency department with 3-day history of fever and loose stools. And these are the investigations. His hemoglobin is normal. He's got leukopenia. His platelet count is normal. Okay. And serum creatinine is not too bad. And with regards to LFTs, there is some elevation of ALT. And with the alanine transaminase, obviously with the other test fairly unremarkable. Oops, sorry. Okay. Right. Okay. And the question is, what is the most likely diagnosis? So basically, he's a guy who had a transplant. Now comes back 2 months later. His kidney function is fairly stable, and he's got leukopenia and elevated liver enzymes. So these are the clues which are there. That's why it's important to pick up the important points. And this happens within the first 2 to 3 months of transplantation. Okay. So what is the most likely diagnosis?
Cytomegalovirus.
Very good. Very good. Very good. Excellent. Okay. So cytomegalovirus infection is the most likely thing. If you suspect, PCP, remember HIV patient, we discussed it last time in the class. Typically, they will have a respiratory symptoms. Yeah, CME can also cause a pneumonitis, but at least in the exam setup, if somebody's got a cough, disproportionate shortness of breath, etc., you have to think of PCP as the most likely thing here. And PCP doesn't typically cause leukopenia or thrombocytopenia, etc. And the loose stools is also the clue. Why does he have a loose stools?
Colitis.
Exactly.
Colitis.
Yeah, CMV also causes colitis. That is the other thing. So it can cause colitis, it can cause renal impairment, it causes the leukopenia, thrombocytopenia. So putting it all together, with the most likely diagnosis, cytomegalovirus infection. Varicella zoster, they would have given some information about the skin. TB is quite unlikely in the first month or 2 of transplants, because usually we would have screened them for TB beforehand, before going for a transplant. Okay. Oh, sorry, just 1 second. Now, what else is important to know about CME is what patient groups are vulnerable for developing CME infection. I mean, these things are just so that you are aware of it. It's not very important, but at least you just have idea. Sometimes they may give a hint about it. So what sort of patient groups will be more vulnerable for developing CME infection?
Transplant.
Solid organ transplants.
Yeah, that's right. Solid organ
Pregnancy.
transplant. My point was, sorry, I probably would have to rephrase that. What group of transplant patient, what group of solid organ transplants will be more vulnerable to CME infection? Is there any particular group? You may or may not be familiar with these things, but just for you to know, see, normally what we do is that we actually check their CMV serology before transplantation. Okay. So because most of us would have been exposed to CME during our childhood or teenage years. So a lot of us may have already have antibodies in the place. So for example, let's say some guy gets a transplant. This guy has never got an exposure to CMV. Let's say CMV antibody is negative, but let's say somebody else is giving him a kidney. That guy had a CMV before. So the CMV will be in the system. So when they get a transplant, this guy who has not had a CMV before will be at high risk of having a CME in the future. So that we call it positive to negative. You guys are familiar with it? If it's not sure, you don't need to know. Basically, positive means, so if somebody's had exposure to CMV already, and the transplant patient also got an exposure in the past, the risk of them developing CMV infection is very, very low. But let's say you give a kidney from a guy who had a CMV infection before, but the recipient never had a CME before, like CME positive to negative, the risk of CME infection is much, much higher. You got that, or if you're not sure, clear?
Got it, sir.
Got it, sir.
Yeah, understood. If not sure, please ask me. Yeah. So the point and the reason I'm saying that is sometimes they may give a hint that this guy got a CMV antibody was negative. So you should not think that that makes it unlikely. That makes it more likely that this guy will develop it if it's negative. But he had a kidney from a positive transplant. These are the guys with the highest risk of CMV. And generally we give them CMV prophylaxis. What drug would we use? Anyone?
Ganciclovir.
Yeah,
Acyclovir.
that's right. Ganciclovir or valganciclovir. Yeah, either of them are fine. I mean, it's just a minor differences between the two, but generally we give them CME prophylaxis for at least 3 months. In some setup, may even be longer than that. Yeah. Okay. So CMV usually happens in the first 6 months, and the major differential is going to be PCP. But PCP, there will be predominant respiratory symptoms. So that is what will give you the clue. The other clue will be the deranged transaminases, leukopenia, thrombocytopenia. All of them will generally won't be there much in the setting of PCP. So you diagnose it by doing a CMV PCR, and the treatment is either ganciclovir or valganciclovir. Yeah. So that is how we differentiate between PCP and CMV. So CMV, as I said, the clue will be the leukopenia or thrombocytopenia, deranged liver enzymes within the first few months after transplant should be the top differential. Respiratory symptoms predominant without any leukopenia, deranged LFTs, etc., likely to be PCP. So that's how we differentiate between the two in the setting of post-transplant. Yeah. The other thing sometimes they will give will be chickenpox pneumonia, but they would have given information about the rash, etc. Yeah. Because chickenpox, almost everybody will develop a rash. Okay. So any questions on that before I move to the next one? No?
No, sir.
Okay. All right. We'll move on. Okay. So question number 6. A 16-year-old boy presents with a decreased urine output and swelling of the face, feet, and ankles. He is unremarkable except for a tonsillectomy performed 2 months back for recurrent tonsillitis. He's got low albumin. Again, the urine protein creatinine ratio was very high, which is 926. Normal being less than 30. So 30 will be equivalent to 0.3 grams per day. So 926 will be equal to 9.26 grams per day. So you can either, sometimes they may give a 24 urine protein, sometimes they'll give a urine protein creatinine ratio. Actually, in clinical practice, I don't do 24 urine collection. I very rarely only will do it actually. So most of the protein creatinine ratio is as good as 24-hour urinary protein collection. Okay. So again, similar to what we discussed earlier, except it's a young person, he's got a nephrotic syndrome, and there is some history of tonsillectomy. So what is the most likely diagnosis? IgA nephropathy, post-streptococcal glomerular. No, please wait. Yeah. Okay. Why do you say it's PSTN? We discussed PSTN last time. I don't know whether you guys, I can't remember whether I thought we discussed it last time. I may be wrong. What this is the think about sometime when they give some hint about some odd information, and we think it's most important or most relevant when it's not the case. So here, post-infectious, what sort of glomerulonephritis will they ever present? So clinical presentation I'm talking about. Here he's got a nephrotic syndrome. Okay. Post-infectious, how will he present normally? They will develop
Nephritic.
Exactly. So they can have a nephrotic range proteinuria, but they will have a nephritic illness. So there will be hypertension, there will be renal impairment, and their urine will be, I mean, they have not, with not much information is there, but there will be proteinuria and hematuria will be there. So here this tonsillectomy is just a red herring, just to confuse you a little bit. But here, this guy has got a typical nephrotic syndrome. So post-infectious GN will not be like that. You will have a more of a nephritic illness. So given that this is nephrotic syndrome, young adult, so young child, teenager, whatever, what is the most likely diagnosis?
The minimal chin disease?
Exactly, that's right. I mean, post-streptococcal GN, we already discussed. SLE, there is nothing to say that this guy has got a, he's got any features of that. It may be, but there's at least no evidence of it right now. Good patches will typically present with hemoptysis, pulmonary and renal involvement, like we discussed it last time. That there is no evidence of a pulmonary involvement, and he does not have a nephritic illness, which makes it unlikely. IgA nephropathy, typically they will say that he had a sore throat, he passed visible hematuria, etc. Again, doesn't typically present with nephrotic syndrome, though it can in an odd place where IgA nephropathy just maybe a bystander and the guy would have got minimal change disease. But anyway, that's more academic. You don't need to worry too much about that. But see, you always look at it, the pathology or the clinical description they given. Is it a nephrotic illness or a nephritic illness? Because a nephrotic, you're going to go through a minimal change disease, membranous nephropathy, FSGS, etc. Whereas if it's a nephritic illness, you're going to think about post-protocol GN, ANCA-positive vasculitis, good pastures, etc. So always look at the clinical picture rather than be distracted by a bit of information given here and there, etc. Okay, so this is a typical case of minimal change disease. So it is the most common cause of nephrotic syndrome in young adults and children. And clinical features will be, we already discussed that. So they will have a generalized edema, hypolinemia, and proteinuria. As I already mentioned, it is the most common cause of nephrotic syndrome in children and young adults. Okay. This is a similar scenario. A 21-year-old man presents with decreased urine output, swelling of the face, feet, and ankles. He has no significant past medical history, does not take any regular medications, and he's got 3+ proteinuria, and there are no RBCs. And blood test again shows nephrotic syndrome. So you've got hypolinemia, edema, and protein creatinine ratio of 9.2. So we know that from the previous scenario, this is given the age and so on, it's most likely to be
minimal change.
Yeah. Okay. Okay. So you've undergone the renal biopsy, and usually what will be the light microscopy will be. That's why it's called a minimal change disease. You will find that it is normal. That's right. What will an electron microscopy will show?
Podocyte
effusion.
Effacement of food processes. That's what it will show. Yeah. So you can wait for that to be done. But generally, even very young kids, actually, people don't even do a biopsy. They'll just give them steroids and see what happens. So in adults, we obviously do a biopsy. And if this is what my report comes, what would I treat them with?
Steroids.
Exactly. Good. Yeah, that's right. So it's a oral steroids. It works absolutely fine. So you give oral steroids, you don't need to go for anything else. Let's say this is a similar patient. Let's say you've given him steroids for 2 months. Okay. But there's not really much improvement in the nephrotic syndrome. Okay. What sort of thought will go through your mind? Or the proteinuria has come down. See, minimal change by definition, it responds very well to steroids. And usually you will see a response within a week or 2 actually in some patients. Some patients you will see it within 3-4 days as well with kids and all. So usually it responds very well to steroids. So you've given somebody steroids, the same patient, let's say, you asked him to give 1 mg per kg, whatever, 40 to 60 mg, given it for 1 month, 1 or 2 months, but he's still nephrotic, let's say. What sort of things will go through your mind?
With the same biopsy report, sir?
Yeah, same biopsy report only. Yeah.
Okay.
So relapse.
No, relapse by definition, that usually happens when you stop the treatment or you're reducing the dose. Yeah. That is what relapse is. So it's not the same. What I'm saying is this guy is given steroids, but taking longer, I've given you a clue already, or not responded that much as you would expect it. Okay. Now you have to go back to what I discussed earlier. You remember focal segmental glomerulosclerosis? Yes, that's right. Yes. Yeah. So that's what you would think. I told you already. No. Why is it called a focal? Because only some glomeruli are affected. So by chance, you've taken a sample from part of the kidney, whatever, does not have the affected area, you could have diagnosed it as a minimal change disease, isn't it? So that's what it is. You have to think of that. I mean, it's FSGS, if particularly somebody's not taking a lot of time to respond to treatment, etc., you will think whether it could be FSGS. The treatment may still be the same, but they may take a longer time to respond to treatment. So that is what the difference is. Yeah. I mean, there are other things as well, but probably not relevant in your setup now, for MRCP teaching. Okay. So, as some of this already mentioned, the majority of the cases are idiopathic, about 10 to 20%. There may be connections. We already mentioned about NSAIDs. Rifampicin can rarely do that, though. The more common thing that other thing I've commonly seen in clinical practice for rifampicin actually is interstitial nephritis. Hodgkin's lymphoma, though other malignancies are generally connected to membranous nephropathy, with regards to Hodgkin's, the most likely diagnosis is minimal change disease, and rarely it can be due to EB virus and infectious mononucleosis. But majority of the cases are idiopathic. So, which is, some of it is I've already answered, that a normal glomerular light microscopy, the electron microscopy will show a fusion of podocytes and effacement of food processes. Treatment, the standard treatment is oral steroids. Most of them are steroid responsive, and at times we may go for cyclophosphamide, particularly in steroid resistant cases. There are other drugs we can use, but not relevant in your setup. And if somebody is not responding to steroid or taking a longer time to respond to steroids, you have to consider whether it could be focal segmental glomeruloscopy because of the reasons that we already discussed. Okay. Any questions on this one?
No, sir.
Okay. All right. No. Okay. No questions. I'll move on. Okay. The 50-year-old female presents with polyuria and polydipsia, which has been going on for about 12 weeks, so it's about 3 months or so. She's got history of hypertension and is currently taking nifedipine and lithium. Okay. So we done, so obviously when you have a lithium, you worry about its effect on the kidney because of the polyuria, polydipsia, polyuria, polydipsia, etc. You've done a water deprivation test, and the pre-test urine osmolality is about 250, and you put the patient on a water deprivation and you check the osmolality. That is very little change. Yeah, it's more or less the same. So so let's say if I make somebody stop, or if let's say I don't drink any water for the next 12 hours, what do you expect my urine osmolality, which should be?
Increase.
Increase.
Exactly, that's right. Exactly, that's right. So that means there is something wrong with the concentrating ability of the kidney, isn't it? Even if you stop water. Okay. So this is, say, lithium is a drug which is rarely used in clinical practice, as far as I know. I mean, I've only seen come across one patient taking the last few years, but it's a very common topic in exams, MRCP exams. There are, certain drugs which are frequently asked in MRCP exams, and lithium is one of them. The other common, I mean, you have other faculty covering it. But, drugs like amiodarone, although it's very, very commonly used, it's very, very common in exams. You need to know in and out of different side effects, different effects, etc. So this is one. Lithium is a very, whatever reason it may be, it's very popular in the MRCP exam because it causes certain classical side effects, etc. Okay, so it's a little bit of the answers are a little bit longer. These are the options. So why does this? Just 1 second. What is the pathogenesis of the likely diagnosis? So you think, what is the likely diagnosis here? It is
nephrogenic diabetes.
That's right. So a patient has got a diabetes insipidus, and based on the history, it's likely to be nephrogenic diabetes insipidus. Okay. So this is options are: is it because lithium desensitizes the ability of the anterior pituitary gland to respond to ADH? It desensitizes the ability of posterior pituitary gland to respond to ADH, or lithium desensitizes the kidney's ability to respond to ADH in the DCT, or is it in the proximal convoluted tubule or in the collecting duct?
Collecting duct.
It's a relatively easy question because in DCT, usually what drugs works in DCT generally? Diuretic. What diuretic? Not loop. Loop, as a name call it, it's in the loop. It's a loop of Henle. DCT comes after that. Yeah.
Potassium sparing.
That's further down. Yeah. I mean, that comes a little bit down. The most important thing is the thiazides. That's right. Yeah. So it's proximal convoluted tubule, acetylcholamide works. Then you have a loop of Henle where Lasix or furosemide works. Then you have DCT where thiazides work. So you should know that because there will be questions on the. I discussed it the other day, like when we discussed Bartus and Gittelman's. Yeah. Bartus, it's the loop thing, and Gittelman's is the DCT. It's like a thiazide. Yeah. You've forgotten that? You remember last 2 weeks back, we had a question on Bartus. I discussed about you remember the way Bartus is like a loop and Gittelman is like a thiazide. So that is how we remember these things. So it's obviously, it's something to do with the water concentration, and that happens in the collecting duct. So lithium desensitizes the kidney's ability to respond to ADH in the collecting duct. So as I said, lithium is important. You should know, as I already said, it's a site of action. Distal convoluted tubule is thiazide diuretics. Proximal convoluted tubule, where the only drug which commonly we use works is acetylcholamide. Usually the problem with the proximal tubules will lead to Fanconi syndrome, where most of the things are reabsorbed, like glucose, amino acid, uric acid, phosphate, bicarbonate, etc. That's why Fanconi syndrome will make all these things to go in the urine. Yeah. So it's the diabetes insipidus. It can either be a cranial or a nephrogenic cranial, where there is decreased secretion of ADH, or in the nephrogenic, where there is insensitive antidiuretic hormone, like in the setting of lithium toxicity. So generally, you will find there is a plasma osmolality is high and the urine osmolality is low, and the urine osmolality is very high. You can safely rule out diabetes insipidus. And the investigation of choice will be water deprivation. So you water deprive them and see what happens to them, whether they're able to concentrate the urine or not. Then you got the answer. Okay. And there are various side effects of lithium. I said lithium is relatively very common in the exam, but 2 to 3 things to bear in mind will be: one will be the tremor. That's something which will be commonly asked. The other thing is diabetes insipidus. We discussed it. It can also cause chronic kidney disease by causing tubular interstitial nephritis. Though it's rare, it does happen. There's something else to bear in mind. And the last but not least, the hypothyroidism. That is also something, drugs, lithium causes hypothyroidism. So there are a lot of side effects. I said lithium is relatively important in the MRCP exam. So you should know the effects and so on. Okay. Just to one additional point, which I mentioned briefly. Does anybody know how do we treat this condition? When it's lithium toxicity, anybody know?
Hydration, sir.
Sorry, ma?
Hydration?
I couldn't understand. What is it? Diet?
No, hydration, sir.
Hydration. No. Hydration is not going to help that, no. Here, diabetes insipidus, because they already have polyuria and polydipsia, no. Obviously, if you drink more water, it's going to make it will just make it even more dilute, no. Usually give thiazide diuretics, okay, because that will induce a degree of hypovolemia, and then that will activate renin-angiotensin system. By that, they will retain the water a bit more. So that is thiazide diuretics are the drug of choice generally for lithium toxicity or nephrogenic diabetes insipidus. It's oddly, it certainly does work. Okay, right. Another patient with a IgA nephropathy. He had a kidney transplant and presents to the transplant clinic with worsening bilateral hand tremor. His renal function remains stable and there is no history of excess alcohol intake. And the question is, what is the most likely cause of his hand tremor? Tacrolimus, alcohol, anxiety, Parkinson's disease, and essential tremor.
Tacrolimus.
Yeah, it's a relatively easy question. Yeah, there's nothing really to say. It could be anything else. Yeah. So tacrolimus, one of the side effects of tacrolimus is tremor. Oops, sorry. Yeah, tremors. And all the other, none of the other things are likely. I mean, alcohol, there is no mention of it. Parkinson's disease is extremely unlikely in the age, someone who's aged 40 years suddenly to come up after transplant. And essential tremor, there will be history of tremor earlier. Here, this seems to be a new thing which has happened after having the kidney transplant. So most likely to be tacrolimus induced. Yeah. So usually, if you reduce the dose, check the level and reduce the dose, usually it gets better over time. Rarely you may have to give a beta blocker, etc. Okay, tacrolimus, cyclosporine. Sorry, 1 second. All these drugs one need to know. And tacrolimus is a preferred drug of choice in transplantation nowadays. We rarely use cyclosporine unless there is somebody who's not able to tolerate it or something like that. It's compared to cyclosporine, you have a lower risk of hypertension and hyperlipidemia. However, in Asian patients, one need to be careful because it does have a higher risk of impaired glucose tolerance and diabetes. What is that diabetes called? Anybody? Does anybody know? Is there any particular name for this one? I mean, there's no special name really, just called post-transplant diabetes. It's typically Asians are quite vulnerable to it, and there is a higher risk with tacrolimus. So you need to know both the side effects of tacrolimus and cyclosporine. And what is the common side effect of cyclosporine?
Neuropathy.
Yeah, can happen. It's very rare though, but there are far more common side effects.
Hypertension.
Yeah, we already mentioned that hypertension, hyperlipidemia, it can happen in cyclosporine compared to more common when it's compared to tacrolimus. The other side effect is more of a cosmetic. Then nobody has seen that.
Hirsutism.
Sorry? Yeah,
Hirsutism.
hirsutism can happen. One more thing.
Alopecia.
No, I don't think. How can it cause alopecia and hirsutism?
No, hirsutism.
Anyone? So that's actually, I'll give some people a clue when they go for PACEs. You examine the patient, always check you concern about transplant, check the gums.
Gum hypertrophy.
Gum hypertrophy.
Exactly, that's right. Yeah, so that is what so if you go for PACEs, I always tell them a clue. At least, check the gums of the patient. But the older patient who come, been a transplant for a long time, one of the common problems you'll find that is gum hypertrophy due to cyclosporine. So that will give you a hint that it can be that, and the longer term will be there is the risk of chronic allograft nephropathy, etc. But so gum hypertrophy, you should always check that. What are the same topic? What are the other drugs which will give you gum hypertrophy?
Phenytoin.
And sir,
Something more common than that?
Calcium channel blockers can use.
Exactly, that's right. Calcium channel blockers like nifedipine, amlodipine, etc. They all have a high risk of gum hypertrophy. Yeah. Okay. Right. Good. Any questions on that before I move to the next question?
We'll move on, sir.
Okay. Fine. All right. Okay. This is slightly longer. I think anyway, never mind. So, a 26-year-old male, university student, presents to the emergency department with polyuria and excessive thirst. He has past medical history of depression and recently started an SSRI. He's got slurred speech. He's got seems to be very active and talking some nonsense. Patient sister tells you that he hasn't slept properly for 3 days and has been taking a lot of alcohol, and along with it, he's also been taking ecstasy. He's apyrexial, normal tonal reflexes, and there's no evidence of clonus or tremor. And these are the investigations. You have a serum sodium which is high, it's 155. Serum osmolality, obviously, serum osmolality, it's derived predominantly from sodium, so it's easy to know. It's 364. Urinary sodium is slightly on the higher side, and urine osmolality is 200. What is the odd thing here? See, you have to look at when you have any electrolyte disorder, anything with the kidney, you have to look at it. Is it appropriate to the problem that you have? That's why you should look at it. So somebody's got a high serum osmolality. What do you expect the urine osmolality should be if your kidney is working properly?
Low.
High inappropriate secretion.
Now, if it is low, how can it be low? Yeah, exactly. It should be high. You have a hypernatremia and a high urine serum osmolality. Your urine should reflect that. If it doesn't, that means there is something wrong with the urine concentrating ability. That's how you look at it. Same, if you have a hyponatremia, look at the urine sodium, it should be low. Like that only you should think. Yeah. So if it's not there, it means there is something wrong with your concentration or ADH, etc. Okay, because typically ADH is what is involved in the concentration of urine as a final step. So here you can see that he's hypernatremic. He's got a high serum osmolality. His urine sodium is on the higher side, but it's normally 10 to 20. It's not very high. It's slightly high, but the urine osmolality is relatively low. So the urine is dilute when compared to the concentration of the serum, which is quite high. So the question is, what is the most likely cause of this patient's hypernatremia? Binge drinking alcohol, diabetes mellitus, ecstasy, primary polydipsia, and syndrome of inappropriate ADH secretion.
Inappropriate syndrome, inappropriate secretion.
No,
Yeah.
come on, we discussed it already. What happens in SADH? You have a extra secretion of ADH. I already told you, ADH works in SADH. What happens is that your blood sodium does not change. The total body sodium does not change. But what you have is because of the extra ADH, you are retaining a lot of water. Yeah. So if you retain a lot of water, what should happen to the serum osmolality?
It should get reduced.
Will reduce.
Yeah, exactly. Yeah. So, but here just to give me 1 second, please. Just 1 second. Someone, 1 minute, just 1 minute, please. 1 minute. Just give me 30 seconds. Just 1 second, okay? Sorry, just 1 second. Sorry, yeah, I'm back. Just 1 second. Yeah, sorry. Yeah. So see, in SADH, what happens? You have, as I said, you have a lot of antidiuretic hormone. So its job is to, we have excess of EDH. What happens is that it's anti-diuretic, as the name implies. So what you have is that you're retaining a lot of water related to the sodium. So serum sodium should be low. Yeah, got that?
Dilutional hyponatremia.
Yeah, that's right. So basically your total body sodium hasn't changed, but because you're retaining a lot of water, the sodium concentration has come down. So that is why you got a hyponatremia and a low plasma osmolality. Okay, it's not that you got a low, lost a lot of sodium or anything like that. It's purely a disorder of water. Actually, it's not a disorder. So I always tell people to remember it as a disorder of water rather than a disorder of sodium. So that is why when you give tolvaptan, what it does is it makes you get rid of the excess water. It doesn't make it a more sodium, or it doesn't make you retain sodium or anything like that. You just make it get rid of the excess water that you accumulate. So the serum sodium corrects itself. Here you got a situation where the sodium is high, and the serum osmolality is also high, and the urine osmolality is low. Actually, in SADH, what happens is it's the other way around. You have a low serum sodium, you have a low serum osmolality, but a high urine osmolality because you are passing less water. So urine is a lot more concentrated in SADH. So generally, your urine osmolality will be higher in the setting of SADH. You got that?
Yes, sir.
Yes.
You see, sodium is very, very important disorder in clinical practice or in the exam setup. So you should understand this. One of the commonest electrolyte disorder that you see in clinical practice is hyponatremia. Okay, and unfortunately, it's often people just put people on tolvaptan without thinking through what's the causes, etc. So anyway, that is not relevant here. So this is why. So this is not, patient does not have hyponatremia. So you can rule out SADH completely. This is not a SADH by definition. You should have euvolemia with hyponatremia. So it's not there. So it's not going to be SADH. Okay. Can it be explained by diabetes? No, isn't it? So in diabetes, it can give you a high serum osmolality if you have a very, very high plasma glucose. Yeah. Here, sorry, just 1 second. They're not given the value of glucose. Yeah. But that does not explain why you got a hypernatremia. Because usually what happens is in diabetes, sometimes you get a pseudo hyponatremia. You guys are familiar with that? Rarely that may be a question on MRCP exam.
Yes,
You guys
yes.
are familiar or not? You need to correct
Yes.
sodium for the glucose. You remember that? So that's just something to bear in mind. So you can have a higher serum osmolality with hyperglycemia, but you do not get hypernatremia. You usually get hyponatremia. Got that? Yeah? Yeah, you guys understood?
Yes.
Yes,
Okay,
sir.
because I said sodium is very important. I know I'm spending a bit of time in the lab because you will get questions on sodium. At least one question will be there in the MRCP exams, etc. MDMA abuse, can it be like that?
It causes more of SIADS like picture, sir.
Correct, that's right. Yeah, generally will cause hyponatremia. There will be history of that sweating, etc. So here, based on the information that we have, this is likely to be primary polydipsia because. Just 1 second, please. Sorry, someone is knocking my door. Just 1 second. I'll just. Please, 1 second. I'm at home. Just 1 second. Let me just. Sorry about that. I'm back. Oh, I don't know what happened. Sorry. So, based on the information here, can you guys hear me?
Yes, sir.
Yeah, okay, fine. Yeah. So, alcohol also leads to ADH suppression, leading to polyuria. So, there is reduced aquaporin in the collecting ducts. So, you have impaired water reabsorption. So, it's like you get it something like a polyuria. You get it something like a diabetes insipidus. Okay. So, the clue is the hypernatremia with raised serum osmolality and decreased urine osmolality. I said, whenever you look at serum sodium or serum osmolality, see whether it is, you look at the urine, you see whether it is appropriate to the current setup. So normally, and then the same logic also applies when you have metabolic acidosis, RT, etc., which we will probably cover in the next time. When I have questions on the next time. So here you have a situation where your serum sodium is high and serum osmolality is high. You would expect it to be high, but it's not the case. So that means there must be some issue with the concentrating ability of the kidney. Okay. Right. Sorry, any?
Sir, what's the answer then?
No, this is this one, diabetes insipidus.
Primary.
Sorry. Primary polyp.
Primary.
Yeah. Because what happens in these people, he's drinking on alcohol, which is caused the ADH. There is suppression. So that is what has happened. Yeah. Got it?
So the first option is binging alcohol, right? Binge drinking alcohol.
Sorry, yeah, that's right. Binge drinking
that's
alcohol.
right.
That's right. That's the right answer. That's right. Yeah. Okay. Okay. This is a relatively easy question. Just 1 second on my slides or something. Yeah. This. Sorry, 1 second. My. The mouse is not responding. Just 1 second. Never mind. So sorry. I hope you guys are able to see it. My mouse is just playing up a little bit. Just 1 second. Just to move it.
I don't know that.
Yeah, I'm showing it again. Sorry, just 1 second. I'm just moving my mouse. Mouse has stopped responding, so I have to exit and come back again. Yeah. So a 59-year-old man who suffers from biventricular heart failure comes to your clinic for review. He's currently taking losartan, spironolactone, bisoprolol, and furosemide. His main complaint is painful gynecomastia, which is developed over the preceding 6 months or so. And you examine him, you find that obviously his heart failure has been corrected very well. And physical examination reveals a blood pressure of 125/80. Renal function is fairly stable. And the question is, a very easy question actually. What is the most likely cause of his gynecomastia?
I don't know that.
Yeah, it's a relatively easy question. My question is, what are the other drugs which will cause gynecomastia? Not familiar?
Metoclopramide, sir.
Sorry?
Metoclopramide.
Metoclopramide. I haven't come across that, I must admit. I may be wrong, but I haven't come across that.
Domperidone.
Sorry?
Domperidone.
No, they usually cause,
Domperidone.
I think you are getting, they all cause your, I got the point. They can cause hyperprolactinemia. So you're wondering through that mechanism, they can cause gynecomastia. Is that what you're talking about? Yeah.
Estrogen.
They will cause hyperprolactinemia, not estrogen. They will cause hyperprolactinemia. Yeah?
Bromocriptine.
Yeah, bromocriptine. Yeah, that's right. Yeah. So here, the other drugs commonly do that will be cimetidine, the hormonal receptor analog for usage in prostate cancer, etc. So all those drugs can cause gynecomastia. So here, the most likely thing is spironolactone, because there's no evidence that he's got hyperprolactinemia anyway. So most likely to be, it's going to be spironolactone. Now, 1 second, I've forgotten to add that point. So what can you do for this guy? He's got heart failure. His heart failure is relatively well controlled. Now he's developed gynecomastia. So what can you do about it?
You stop spironolactone.
Yeah, good. So what if heart failure flares up again? What are you going to do?
No, you can add on to either SGLT2 inhibitors along with non-steroidal MRAs.
Good, very good. Okay, I mean you can either. I mean, there are non-steroidal MRI is a newer one, which is the finerenone. You know, we discussed it the other day. But other options you can also go for is eplerenone. Yeah. See, either of the drug is fine. Eplerenone has got a lower risk of gynecomastia compared to spironolactone, and finerenone is one with the least risk of gynecomastia. So either of those drugs is fine. Finerenone is a relatively newer drug, so they may give the option of eplerenone in the exam because they're not necessarily may not be up to date with the latest stuff by the time the MRCP questions come out, etc. So in case patients are not able to tolerate spiro, you can switch them over to eplerenone or finerenone. Okay, you can add an SGLT2. My point was specifically with regards to mineralocorticoid receptor antagonist. Okay, so spironolactone interface with the binding of testosterone and androgen receptors. So there is increased metabolic clearance of testosterone and increased metabolism of androgens to estradiol. So obviously, it's increased estradiol. That is what leads to gynecomastia, and sometimes it can be quite painful and troublesome for our patients. Right. Next question. This is similar to what we discussed the other day, actually. Which one of the following is not a feature of HIV-associated nephropathy? Small kidneys, large kidneys, elevated urea and creatinine, proteinuria, and focal segmental glomerulosclerosis on renal biopsy. Relatively easy question, actually.
Small kidneys.
Small kidneys.
Okay, it's a relatively easy question. Yeah, that's right. So you remember the other day we had a scenario. So usually in HIVAN, you get big kidneys and elevated urea and creatinine. They often have nephrotic and proteinuria. Typically, they don't have much edema, and biopsy will show FSGS. What sort of FSGS, you guys remember?
HIVAN.
No, that is the short term for HIV-associated nephropathy. It's already there. What I meant is what sort of FSGS you will see in the kidney biopsy. We discussed it only the other day. I thought somebody answered me that day. Actually, I didn't realize you all forgotten it. The FSGS, there are different types. And what is the type of FSGS which is which you see?
Collapsing focal.
Excellent. Very good. Yeah, it's collapsing FSGS. That's typical of what you see in HIV nephropathy. So just because sometimes they'll put a picture and ask you what sort of FSGS you will see. There are different types of FSGS like depletion, etc. So collapsing FSGS is what you typically see in HIV-associated nephropathy. Now, same thing. Another question: what is the other nephritis that you will see in HIV and kidney disease? You guys remember that? Again, I discussed it the other day. Just a refresher for me.
Immune complex disease.
That's right. Immune complex GN. That's right. Yeah, that is the other thing you have to bear in mind. Yeah. So typically, particularly the Afro-Caribbeans are more vulnerable to FSGS. Non-African Americans or non-Afro-Caribbeans, you will see the other thing which you'll see in kidney biopsy will be immune complex mediated GN. Yeah. So just something to bear in mind. Yeah. So it's just like refresher ready for what we discussed the other day. So you'll get these patients get a lot of proteinuria leading to nephrotic syndrome. Kidney size either normal or enlarged, and the biopsy you will see a focal segmental glomerulosclerosis, and often these patients present with moderate to severe renal impairment, so they will have increased urea and creatinine. Okay. Right. Next question. 28-year-old man who is quite fit and well. He presents with vomiting for the past 2 days or so. He hasn't passed any urine for the last 24 hours. He's generally fit and well, no known comorbids. He's got no headache, no visual disturbance, no seizure activity. He denies the use of illicit drugs, and he's been passing normal stools with no history of abdominal pain or no other GI symptoms or note apart from the vomiting. On examination, he is alert. Sorry, chest is clear. His oxygen saturation is okay. Blood pressure is not too bad. Heart sounds are normal. He's got no murmurs, and the neurological examination is also normal. Neurological is also normal. Okay. Yeah. I'm sorry about this one. It's just that I was trying to correct it last night. There is a little bit of a problem. I'm sorry about that. See, basically, he's got a. I will read it out. Yeah, just give me 1 second. 1 second. Just give me 1 minute. So I will read out the reports that this hemoglobin is 7.8, his white cell count is 11,000, that is normal. His platelet count is 70,000, okay? And his investigation shows that his sodium is 140, potassium is 5.1, and creatinine is, just 1 second. Sorry, creatinine is 980 micromoles per liter. 1 second. Just give me 1 minute, 30 seconds, please. It's my fault. I didn't realize. I thought I did them. Okay, 1 second. Yeah. So you can see that his hemoglobin is okay. Sorry, he's anemic. He's got thrombocytopenia. His sodium and potassium are normal, and his serum creatinine is elevated at 980 micromoles per liter. So this guy has got a severe renal failure with thrombocytopenia and anemia. Okay. So his serum LDH is elevated at 480. Bilirubin is high. ALP, ALT, etc. are not too bad, and prothrombin time and APTT both are normal, and this fibrinogen is normal, and reticulocyte count is little bit high. Okay, you've done few more investigations. That your rapid stool test is negative for Shiga toxin. The blood film shows cystocytes. Coombs test is negative. Complements are normal, and ADAM TS13 activity is also normal. This is the blood film. Anybody know what it shows?
Helmet cells.
Yeah, that's right. There are some cells are helmets. Some of them are
Fragmented.
Yeah, that's right. So he's got a fragment because what happens is in this system, sorry, in this situation, when these red cells go through small capillaries, because of the thrombi there, they're not able to get through, so they get broken up. So that is what you get. Typically, you'll get in this condition. He's got fragmented RBCs. Okay, so forget the likely cause. What is this sort of picture called in the clinical context? What do we call it?
Maha, sir.
Excellent, very good. This is called microangiopathic hemolytic anemia. Okay, so what are the causes of microangiopathic hemolytic? We'll go to the diagnosis in a minute. That is, MAHA is also quite common in MRCP exams. So, what are the typical causes of MAHA?
HUS, hemolytic uremic syndrome, TTP.
Hemolytic uremic syndrome, yes.
TTP.
IT.
Not IT. No, ITP is completely different. Okay, TTP is right. Yeah, yeah. Don't use short forms because there are other people may not know. Yeah, TTP is thrombotic, thrombocytopenic purpura. Huh?
Yes, sir.
Hemolytic uremic syndrome.
Yeah, we already mentioned that, no? Somebody already mentioned that. Hemolytic uremic syndrome, what is that called? TTP, thrombotic neutropenia. You do see that at times with...
Disseminate intervascular coagulation.
No. You guys have to remember that is completely different from this picture. Okay. See here, the clue is that the clotting profile will be normal in this MAHA. Whereas in DIC, you will get deranged clotting. Yeah. See, disseminated intervascular coagulation, what happens? You will have a elevated prothrombin time, elevated APTT, and also fibrinogen level will be high. Here, what you have is evidence of hemolysis. So here you have elevated LDH, elevated bilirubin, and normal clotting profile. That is the hallmark of microangiopathic hemolytic anemia. Yeah. So this is not DIC. DIC, where you would see it in the setting of sepsis, etc. That is not directly connected to this one at all. Okay, got it? Yeah, understood or not? If not sure, you can ask me again. Yeah, so that is completely different. That is how you differentiate it. In DIC, the clotting parameters will be abnormal, whereas in MAHA, the clotting profile will be normal, but you will find there is evidence of hemolysis as evidenced by high LDH, etc. And if it is Coombs positive, think of ITP, etc. But here you don't get that. So in the setting of renal impairment in MAHA, the top two differential are top two differential are what is that? Thrombotic thrombocytic purpura and hemolytic uremic syndrome. And the other causes are something like a preeclampsia. Eclampsia also you can get a similar picture. Okay, so that's the other differential one need to be aware of. And the last but not least one, any other causes? I didn't realize. And this is MAHA is very important in university exams. Okay, so what are the other causes? Anyone? No?
PNH.
PNH can also give you that. Paroxysmal nocturnal hemoglobinuria can also do that. The other thing to bear in mind is scleroderma crisis, okay, or hypertensive emergency. So that also can give you a similar picture. That is microangiopathic hemolytic anemia. So somebody's got what you call is a hypertensive emergency, or what we used to call it malignant hypertension or accelerated hypertension. You can develop that. And likewise, you can also get it in scleroderma crisis, can also give you a MAHA type picture. We haven't questioned scleroderma crisis, but that's something to bear in mind. Generally, the clue will be that the blood pressure will be very, very high. Here, blood pressure is not very high. So that's will give you the clue if it is accelerated hypertension as well. Okay. Right. So what is a likely underlying diagnosis? Atypical hemolytic uremic syndrome, typical hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, paroxysmal nocturnal hemoglobinuria, and disseminated intravascular coagulation. So we already discussed it. It's not going to be DIC, yeah? Because we already mentioned that clotting profile is normal. So in DIC, you will find that the fibrinogen level will be high, PT will be elevated, APTT will be prolonged. You got that? Yeah? So it's not going to be disseminated intravascular coagulation. Paroxysmal nocturnal hemoglobinuria, there's no history which mentioning that does not explain the renal failure. In paroxysmal nocturnal hemoglobinuria, you don't get renal failure generally. Yeah? So that is also not going to be the case. This guy has got renal failure and other parameters. Sorry, coming to that so that I can show you the clinical findings again. So he's got renal failure with evidence of microangiopathic hemolytic anemia. So your differential is going to be between thrombotic thrombocytopenic purpura, typical HUS and atypical HUS. You guys know what typical HUS is? Anyone? What's typical HUS? Like HUS and all is very common in MRCP exams. What is typical HUS? Anybody?
Secondary to GI infection.
Secondary to what infection?
GI infection.
What GI infection? You have to be more specific than that.
E. coli.
That's right. Yeah, that's right. Good. It's E. coli 0157. You've forgotten that?
Hemorrhagic.
Oxygen.
Hemorrhagic.
Hemorrhagic.
No. That's why it's not hemorrhagic. It's hemolytic uremic syndrome.
Huh.
It's due to E. coli 0157.
Yes.
That is what the organism is commonly implicated. And you see that generally in children, though it can happen in adults as well. There's been outbreaks of these drugs in condition in multiple countries. Germany, it's happened. UK, it's happened. Particularly people eating beef or meat, which is not very well cooked. So E. coli can survive the heat, or particularly if the meat is not well cooked, and get entered into the system and cause very nasty HUS. People can lose, some people may be vulnerable, that's why they're developing. That is what we call it as typical HUS. In atypical HUS, what happens is there is issue with complement activation. Okay, so these people will have a problem with there's different mutations are there. So there may be the common one is something called the factor H mutation, etc. Just something for you to be aware of. That's all. So these people where there you will find that there is no evidence of diarrhea, there is no evidence of E. coli infection, then they may have what we call this as atypical HUS. Okay, in thrombotic thrombocytopenic purpura, typically there is a lot of overlap between these syndromes. But in thrombotic thrombocytopenic purpura, how do you differentiate that?
Neural involvement.
Exactly. That's
Neurological symptoms.
So in the same scenario, somebody is given to you, but they say patient developed seizure, there's some other neurological issue, then you have to think of TTP as more likely. So here, there is no history of diarrhea, and there is no history of seizures or neurological symptoms. So based on all the information, it's likely to be atypical HUS. We discussed it, no? Yeah.
Atypical.
Yeah, that's it. Because I said typical, there will be diarrhea. I showed you the history. There is no evidence of diarrhea or anything like that.
Diarrhea, yes.
Yeah. So if there is a history of diarrhea, you will think of typical HUS. If there is no history of diarrhea, you think of atypical HUS. If there is history of seizure or anything like that, you think of TTP. That is how you differentiate. Because the bottom line, that what you see in the peripheral smear, that the microangial hemolytic anemia with renal impairment is going to be similar across all these three conditions. But based on the history and the clinical information you have, you differentiate what is likely to be. Okay? Got that?
Yes.
If it's not clear, please ask me, because
sir,
this is very important in the typical HUS, atypical HUS, and TTP. These are all relatively, not common, but I'm sure there will be at least one question on that in MRCP exams.
Sir,
in
how
part one or
how
part-
will be the presentation in atypical HU, sir?
It will be similar to what we do. People will, there may be a history of fever or something like that. The other
Okay.
time, you may see that it will be in pregnancy at times.
Okay.
Sometimes pregnancy acts as a trigger in these patients. Sometimes it could be just after some sort of a viral infection or something like that. But the clinical presentation will be very similar to what we've seen. I mean, the investigation which I'm talking about, because from clinical presentation, you're not going to be able to distinguish it. Only on the biochemical and laboratory parameters, you're going to come up with a diagnosis. And if there is a history of diarrhea, think of typical HUS. There is no history of thinking of diarrhea, think of atypical HUS. If there is neurological involvement, etc., you will think that's likely to be thrombotic thrombocytopenic purpura. The other thing will be, I don't know whether any of you noticed that. The test we do that will be Adam TS13, which is a metalloprotease. You guys familiar with it? You might have heard about it.
Yes, yes.
So the Adam TS activity will be low in TTP.
Yes, sir.
It will be normal in the setting of HUS. So that is the diagnostic test that people will do. And here, I said it's a microangiopathic hemolytic anemia. The typical one is secondary to E. coli 0157 and is more common in children. Adults, it's relatively rare. And the atypical HU is usually due to some defect in the complement pathway, particularly the alternative pathway. There are some various mutations, etc., which is probably not relevant for MRCP level, but if somebody is going to nephrology, they will know. So here, as I already mentioned, the coagulation factors will be normal. So usually you find that the prothrombin time, APTT, etc., are all normal, and there is not much evidence of infection. So sepsis can give a picture, but usually sepsis will give you DIC, that is a disseminated intravascular coagulation. Okay, so this is good. Based on the information that we have, it's likely to be HUS and likely to be atypical HUS, and actually the standard treatment is plasma exchange. Actually, we can use this very, very expensive drug called eculizumab. It's very, very ridiculously expensive. Actually, it's available in UK, US, etc. In India, I'm not even sure of the availability. It's how easy it's getting. It costs millions of dollars. I think it's the 1 year treatment itself. It's around about $500,000 to $600,000 or something like that. It's very, very expensive drug. But theoretically, you should know eculizumab is what is the drug of choice for this condition. Okay, so the hemolytic uremic syndrome, you have to think of it when there is a triad of acute kidney injury, thrombocytopenia, and microangiopathic hemolytic anemia. Okay, so most cases are typical. Then it's due to a Shiga toxin producing E. coli, which is 0157. They will present enterohemorrhagic fever, etc. The most common cause in children, leading to over 90% of the cases. Rarely you can see that in the setting of HIV. Rarely you can see it in malignancy, SLE drugs, etc. But relatively, those things are all relatively rare. And the primary HUS, which is the atypical HUS, also called, it's due to some issue with complement. Okay, so we've already been through it. So you'll have a microangiopathic hemolytic anemia with a negative Coombs test. The blood film, you'll find fragmented RBCs. There will be renal impairment, and you can do PCR for Shigella toxin, etc. Treatment is generally supportive. Usually there is no role for any antibiotics. Usually you will give plasma exchange, and then you can use this eculizumab, which is a C5 inhibitor monoclonal antibody, but as I already mentioned, it's very, very expensive. Right. I will stop with that. I'll do the next questions in another class. If anybody's got any questions or anything like that, I can answer that. This is, as I said, you must read about. I think I covered most of the important points with regards to MRCP exams because sometimes there will be. Sorry, go on.
Sir, is there any role for steroids in MAHA?
No, absolutely not. Some people give it, but there's no scientific evidence for its benefit in the setting of HUS and TTP. Absolutely no evidence whatsoever. And you don't use that.
Sir, what will be the diagnosis if direct Coombs test is positive in this patient?
Coombs test is positive, then you have to think of ITP, etc. But that's not going to be the case in this set of scenario. It should not be positive here. Yeah.
Okay, sir.
Yeah, because based on the information we have, it's not going to be a Coombs test positive scenario. So it's unlikely they will give a scenario like that with Coombs test positive.
Okay, sir.
So here the questions may be, they may ask what bacteria, what pathogen is involved in a typical HUS, what could be the, they may give a blood film and say, what does it show? What are the causes of that, which one are the likely cause, etc. And I already mentioned how we differentiate between the three interlinked conditions. That's typical HUS, atypical HUS, and TTP. There may be a situation with a pregnant lady present with a similar finding. Likewise, what is the treatment of choice that they may give a drug, or what is the mechanism of action of eculizumab, etc. It's
Okay.
This is a bigger topic. That's why I got a few points about it so that you guys know about it. Yeah, you can read about it. If anybody's got any questions, I can answer them.
Sir, HUS triad includes acute kidney injury, MAHA, and
thrombocytopenia. Yeah, that's right. And usually the clotting profile will be normal. And you will get, as it name inside, hemolytic uremic syndrome. So you'll get the evidence of hemolysis, there will be renal impairment. Yeah. But typically in TTP, patients often present with very high blood pressure, and other typical finding will be seizures or neurological involvement. I'm not sure whether anybody sent any question, but no, there's nobody's put anything in the chat. So because I usually am not able to see that when I'm doing the class. So any other questions on the topics that we discussed? I covered a range of areas like polycystic kidney disease, transplant, a couple of infections in the transplant, side effects of transplant drugs. We talked about lithium, read about all those things. That's why it's important. I said, in the exams, the questions will never be the same. So always, go through so that you understand the topic, read a bit about the relevant things which may get asked in the MRCP exams, etc. I said, drug toxic lithium is a very, very, very important drug in the MRCP exams, at least. Clinical practice, we don't use much. Okay. Any other questions in the topics that we discussed? Asked a question 1 second. See, it can be, someone asked a question about how do you differentiate between nephrogenic DI, primary, etc. See, the clue is usually primary polydipsia. If you give them a water deprivation test, the urine will concentrate. Okay, because there's no issue with the ADH as such. With regards to nephrogenic and cranial DI, it can be very tricky. You have to go with the history and the information available, because the clinical findings and the laboratory parameters are going to be very, very similar. The only difference in nephrogenic DI, if it's a cranial DI, give it desmopressin, it should respond to that. Yeah?
Yeah, okay, sir.
Whereas this one, it won't respond.
Okay.
Nephrogenic DI. So the treatment of choice will be, what is that? You will give a thiazide diuretic, as I already mentioned. Yeah. But usually in cranial DI, there will be some information about some drugs they are taking, or history of trauma or something like that. Yeah. All right. So, okay, if there's no more questions, I'll stop and I'll see you at the next class. Okay.
Thank you. Thank you,
okay,
sir.
sir. Thank you.
All right. Okay. Good
Thank
night,
you, sir.
everybody. Okay. Not a problem. Good night.